Hi, everybody. Thank you for coming today. Some of you may have already heard I am not 100%. I'm a little under the weather, so this is why I sound like I just inhaled a tank of helium. But nonetheless, we will plow forward. Today I'll be speaking a little bit about my research on peer similarity and the use of online and in-person supports amongst adult children caregivers. Doesn't want to click through. Oh, there we go. So just by way of outline, I'll start off by telling you a little bit about myself, and I'll discuss some of the background info for my research because there are quite a few why questions that I get with my topic. I'll move into the specific objectives of the work and the methodology that I used, and then I'll share with you some of the qualitative and mixed method findings, and finish off with some of the implications of the research and how some of it's already been applied. So about me, Sandra mentioned, I received my master's and my PhD from the Rehab Sciences Institute at U of T, and I did complete a MyTax Elevate postdoctoral fellowship working with Dr. Louise Rose at the Faculty of Nursing and with St. Elizabeth Healthcare as well. I began my St. John's rehab scientist position at the beginning of October, so I'm pretty fresh blood. So I'm looking forward to getting to know everybody and all the work being done here. I'm an interdisciplinary health services researcher, so you'll see from my work that it usually lands somewhere at the intersection of rehab, gerontology or aging studies, and transitional and community care. I'm trained in both qualitative and mixed methods, and I really do believe that integrating those methodologies gives us a more complete and holistic understanding of patient and family experiences across the care continuum. And finally, I'm a huge advocate for patient and family-centered care and patient and family-centered research. Just as an example of that, I wanted to share that we've recently been awarded a Sunnybrook Patient and Family Education Grant, where we're going to be developing a brochure about patient and family engagement and rehab research that we're going to distribute here at St. John's, so that's exciting. So I'm going to jump into some of the background info for my research. Like I said, there are quite a few why questions I get, and I'm just going to kind of go through those with you today. So the first and most obvious one is why focus on peer support in the first place? And to answer this question, I really have to take you back to the very beginning of my research journey, where I was doing my research, my master's research with daughters caring for a parent who survived a stroke. And my focus with this research was really to understand how the relationship between the daughter and the parent changed once they took on the caregiving role, and to sort of understand how they managed other roles in their lives. So what I learned, and it wasn't super surprising, was that daughters really do experience a lot of role overload. So they were often employed, they had partners and children of their own, and so in addition to parent care, those things tended to conflict, and often they felt overwhelmed, and it meant putting other things that were important to them on the back burner. Also, the relationship with their parent definitely did change, especially for daughters who had a very positive relationship with their parent throughout their lives. They felt that when there were cognitive declines because of the stroke, their parent was sort of a different person, where they would have been dependent on the parent for most of their life. Now their parent was dependent on them, so there was a role reversal. So a lot of the discussion was categorized by grief and loss for them in terms of that valued relationship. So this really told me that support efforts need to focus on mitigating relationship declines so that they can maintain those valued relationships and also help them maintain their involvement and participation in other valued roles. So this so far has nothing to do with peer support. But the beautiful thing about qualitative research is even when you go in looking at something specific, often other things come out. So what I constantly heard from daughters was something about peer support. So some of them would say, it would be great to talk to somebody about this. I remember one daughter said, you know, there could even be somebody in my own neighborhood that lives close by that's going through something similar, and we could be connecting and interacting and helping one another, but we don't even know that we exist. So this sort of idea of peer support got ingrained in my head, and as I was deciding to go into doctoral studies, I wanted it to be the focus of my doctoral research. And so I delved more into the peer support literature, and what I learned is that peers are a very key source of social support, especially for family caregivers. So when we're talking about peers, we're talking about any other person who's providing care to a loved one. And in terms of social support, it can be informational support, it can be tangible support, so taking somebody to an appointment or lending them a piece of equipment. But I would argue that the most important type of support, especially from peers, is the emotional and appraisal support. So emotional support being just somebody to lend a listening ear or a shoulder to cry on. And in terms of appraisal support, just evaluative feedback from somebody who's been in that situation and can sort of say, I went through that and you're doing a great job, or have you considered doing this differently? When social support comes from peers especially, there's an element of mutual understanding and empathy that kind of creates these more supportive and valuable relationships between caregivers. And ultimately, peer support can decrease caregivers' isolation, it enhances their self-efficacy, it equips them with coping skills, and all of this is to say that ultimately it does reduce stress. So peer support, very important. So the next question I often get is, why focus on adult children caregivers? The answer to this one is pretty straightforward. Due to demographic trends, we're seeing more and more adult children take on the caregiving role. So in the US and Europe, 49% and 30% of all caregivers are adult children respectively. In Canada, 62% of caregivers over the age of 45 are adult children. And with this trend towards longer lifespans, what we're seeing is adult children providing more and more complex care for one or both parents who may have multiple comorbidities for a longer period of time. And as you heard with my research with daughter caregivers, often the parent care role can compete or conflict with other age normative responsibilities. And so this really highlights or underscores the need to provide support to this growing population. Next up is why look at peer similarity. So we know from a lot of non-caregiving research that peer similarity promotes supportive relationships. So this idea that when you're more similar to another person, a stronger or more fruitful relationship will ensue. In terms of caregiving research, when I actually looked at it, what I found was that most of the research was interventional, and this was ultimately focused on matching caregivers on certain qualities in hopes that that would result in stronger relationships and better support. What was interesting from this body of research, though, is that it tended to show very modest improvements in caregiver health outcomes and quality of life when you match them. However, in qualitative research, when asked, caregivers constantly spoke about how it was valuable for them to interact with people who were in similar situations to them or were similar to them in various aspects. So to me, this spoke to the need to sort of reconcile the lack of interventional efficacy with the fact that caregivers seem to value being similar to someone that they're interacting with and getting support from when it's sort of naturally occurring on a day-to-day basis. And finally, why online versus in-person support? So we know that the internet is very cost-effective and accessible for most people in terms of delivering and accessing support. Given the adult children caregiver population, they tend to be already quite proficient with internet and online resources. And so many of them are now turning to the internet due to geographic and time restrictions to gain information and support from their peers. When looking at existing research, what's interesting is a lot of it focuses on analyzing online discussion forums between caregivers to sort of understand the content of the discussions and what's happening there. Or it's focused on developing and evaluating an online program or intervention for support for caregivers. And typically that's done in isolation, so we'll only look at online support versus looking at online and in-person supports, for example. So we have very little insight into how caregivers use both modalities to sort of gain support and use them in conjunction with one another. And so that sort of leads me to my research, where my first objective was to explore adult children caregivers' everyday experiences with both online and in-person peer support. And secondly, to investigate how peer similarity and support perceptions were associated when caregivers were engaging with peers in an everyday circumstance. So in terms of methodology, this was a mixed method study. For the qualitative portion, it was a descriptive qualitative approach. For the quantitative portion, it was a web-based survey design. To participate in the study, caregivers had to be 18 years or older. They had to speak English because I do not parler français trivia. They had to be centrally involved in the care of their parent, where I categorized centrally involved as assisting with one ADL or one IADL at least once a week. And just an interesting point on that, because this kind of comes up in caregiving research. What I found initially when I did this was that I had a question saying, are you a caregiver, yes or no? And then I had the question about, are you providing assistance with at least one ADL or IADL at least once a week? So I found that people were responding, no, I'm not a caregiver, but yes, I am providing assistance at least once a week. And so this, I felt, spoke to the larger issue we have right now about caregiver self-identification. And so I actually ultimately took out the are you a caregiver or not and just left it as how much assistance are you providing. They also have to be assisting their parent in Canada and interacting with at least one other caregiver, whether it be online or in person. So I went through the gamut of recruitment efforts. I could give a whole 1 hour talk on this alone, but the nutshell version is that I went through several in-person support groups where I distributed flyers, and online I did a huge Twitter campaign for this project. Actually, I ended up writing a paper about how I used Twitter to recruit for this research. And I also used Facebook ads and the social media outlets of many non-for-profit organizations. So in terms of the procedure, basically, people clicked on the Fluid Surveys link. It took them to that eligibility criteria page. If they were eligible, took them to the survey, took them to the consent form. If they consented, they went to the full survey. And at the end of the survey, they were asked if they'd be willing to be contacted for a telephone interview. And if they said yes, we collected their information. In terms of data analysis, the qualitative portion was a thematic analysis, and the quantitative portion, we ran a hierarchical linear regression. So the good stuff. In terms of the qualitative study, I'm going to share with you some of the findings in terms of their experiences with online and in-person peer support. So in total, I had 15 caregivers complete qualitative interviews. On average, they were 51 years old, and unsurprisingly is aligned with current demographic trends. 66% were daughters, which I was still quite thrilled with, that we actually managed to get some son caregivers that we interviewed and got some insight from. In terms of the communication modality, we asked them what they use primarily to interact with their peers. 9 said primarily they interacted in person, 6 said primarily online, but interestingly, 11 of them said that they used both modalities as well. In terms of who their caregiving peers were, it was primarily existing network members. So for other family members that were either caring for the same parents or siblings, or family members that were caring for other people, friends that they interacted with on a regular basis, as well as coworkers. So the first major theme we identified from the qualitative findings was that adult children caregivers are so incredibly pragmatic in the way that they exchange peer support with one another. So they basically got the support they needed by whatever means necessary. So they used a blend of communication modalities. Some of them even talked about using telephone support. And they basically chose the modality they used based on their needs, whether those needs were relational or whether they were practical. So when I say relational needs, I'm talking about, wanting to have a quality, one-on-one, deep discussion with another person. If that was their goal, they felt that they wanted to do that in person. So as one caregiver put it, face-to-face contact is always better than any other contact. It's better for my mental well-being because in crisis, I hide and I isolate myself. And part of my well-being is making sure I continue to interact with people face-to-face. On the other hand, if they were looking for a practical way to interact with their peers. So we're talking fast, efficient, convenient. Online was the way to go. So one caregiver said, I can fit it into whenever I need to use it. I don't have to go out to do it. I have the technology in my pocket to be able to connect to a whole bunch of people that have way more experience than I do. And I remember another caregiver even said, I can send out a tweet and have tons of peers and experts respond to me instantly. So online was definitely the favorite when people wanted things to be fast and convenient. The second major theme was that the type of support that the caregivers received transcended the interaction modality. So this is to say that they received emotional, informational, appraisal, and tangible support, regardless of whether they were interacting online or in person. Again, speaking to how pragmatic they were. So in terms of the mixed method findings, this is where I was looking at how peer similarity was associated with support perceptions from peers. So I actually had 71 caregivers complete the online survey, which was miraculous after months of recruiting. On average, they were 51 years old, and again, 90% daughters. I would have loved to see more son caregivers, but beggars can't be choosers, so we're pretty happy with that. In terms of the findings, there was a positive and significant relationship between peer similarity and perceptions of support from a peer. So this is to say that peer similarity predicted support perceptions above and beyond other variables, but quite modestly. So we controlled for things like the amount of care provided, dependence of the care recipient, even personality traits like extroversion, and sociability and things like that. And yet peer similarity still predicted it more so than all those other variables. In terms of the qualitative piece, the overriding theme here was that shared caregiving experience is the most important aspect of similarity when it comes to peer interaction. So when we're talking about shared caregiving experience, we're talking about elements of the care situation. So caring for an elderly parent as well, caring for the same illness population, being at a similar point along the caregiving trajectory. And all of these things were far more important to caregivers than them interacting with somebody who was the same age, who was the same gender, or who was more geographically close to them. And the reason the shared caregiving experience was so important was because it strengthened the relationship with their peers. So it created these deeper, more understanding, more empathetic relationships that caregivers felt were far higher quality. And also it optimized the support they received from their peers. So because they were more similar in the situation, they felt that the feedback was far more tailored and more specific to their situation. And ultimately that support was better and more valuable to them. So what are the implications of all of this? And I've kind of broken this down into practice, policy, and research implications. So on the practice side of things, it's very obvious that caregivers receive the same type of support that they would be afforded by an intervention. They're very pragmatic, they're very capable, they seamlessly blend these modalities to get the support that they need. So what this tells me is that if we are developing interventions, they have to be pragmatic so as to align with what caregivers are already doing. Otherwise, we're not providing anything extra for them. The other thing that I found interesting is that there might be a wealth of peer support that is already existent in a caregiver's network. So when I went into this research, I kind of assumed the caregivers would tell me about these wonderful online peer support groups that they had uncovered, or these in-person groups they were going to, and they would answer the survey based on these new peers that they were, developing relationships with. But what was interesting was that it was people that were already in their lives. And so from a clinical standpoint, frontline staff can use this information to flag caregivers that may be at risk for not having those types of supports already in their networks. And on the other hand, for the caregivers that do, they can sort of encourage them to mobilize those existing peers for support and help them identify them. From a policy standpoint, one of the most interesting things I found, like I said, was that caregivers were receiving support on a day-to-day basis from activities that they were already involved in. They were, getting support from siblings or other family members during family time. They were getting support from their co-workers. And so what this says to me is that we need to be helping caregivers remain engaged in valued activities. And this can include creating more flexible work structures, so rather than 9 to 5 days, telecommuting, or flexible timing, providing respite such that caregivers can continue to engage in activities that are important to them. I know with my research with the daughter caregivers, often they said, I don't go to the gym anymore because I need to be with my parent all the time. Like I don't have time to go to the gym. Or we used to, as a family, go on vacation a lot. We don't have the money, the resources, or the time to go on vacation. And so making sure that they have respite and financial support to remain engaged in those activities is very important. And finally, from a research standpoint, and this for me was the tricky part, because peer support as a naturally occurring phenomenon is extremely difficult to replicate as an intervention. But as a researcher, we're very intervention oriented. So this was quite challenging for me to grapple with. What I took away was that extensive peer matching is likely unnecessary for interventional efforts. It seems that caregivers are pretty good at finding people who are in similar situations to them, so as to get that appropriate or tailored feedback. And they're also, like I said, very pragmatic. So when we're developing or introducing interventions or support programs, we need to make sure that they're multi-component and that they give caregivers the freedom to choose the way that they're interacting with their peers and how they're using that resource. And finally, we need to be thinking about how to evaluate these peer support interventions in terms of the feasibility of developing and implementing them, and how well they're being used by caregivers, and ultimately how are they impacting health and social outcomes. And so I wanted to sort of wrap up with how all my learnings have sort of been applied to date. And this is really my postdoctoral research, where I worked on developing an online peer support program for caregivers of ventilator-assisted individuals living in the community. And so I tried to take some of those lessons that I learned. First of all, no peer matching necessary. So what we did was actually we trained several caregivers to act as peer mentors, and we introduced them to the rest of the participants in the group and said, you know, here's a bio, here's information about them. Feel free to connect with whoever you think might be best to answer your questions or provide you with the support you need at any given time. We also created this multi-component online peer support program where there was the option to access informational resources about caring for someone at home, caring for yourself, and caring at the end of life. There was also an open forum discussion where caregivers and mentors could post questions and comments and respond to each other, and everybody could see this. There was also a private chat option. And the neat thing about the private chat option is because that I learned from my research that sort of that in-person or face-to-face interaction was still important to caregivers, we introduced a video chat option. So caregivers could interact with each other using text. They could video chat. They could do it one-on-one, or they could even create private groups with several people that they could do a video chat with or a group chat with. And only the people in those groups could see this, so this wasn't public. And finally, we hosted a live text chat every week with a different topic, sort of to make sure that we were gathering everybody at least once a week and having them get to know each other and interact. And so topics included things like setting boundaries, taking care of yourself, finding resources, or navigating the system. So in total, we trained 5 caregivers to act as mentors, and we had 8 caregivers participate in the trial. Quite small, but as you can imagine, with caregivers to those who are on a ventilator, they're sort of at the extreme end of caregiving. And so oftentimes, even if it is something that's intended to provide them support, the idea of being involved in yet another thing can be quite overwhelming for them. So we were quite happy with the numbers here. We're evaluating the feasibility of delivering the program. So we're looking at the usage by the caregivers and the mentors, the usage of the specific features of the website, and the extent of one-on-one interactions. And we're doing a preliminary evaluation of pre to post intervention changes in health and social outcomes, including things like caregiver impact, mastery, coping, personal gain, positive, negative affect, as well as depression. And so this evaluation is ongoing, and it'll be interesting to see what we learn from this. So that's all I've got for you today. Thank you guys so much. I just want to acknowledge some of my collaborators with this work in the past, and this is my most current contact information, so I'm more than happy to have anybody reach out to me if you'd like to chat further about anything, and I'm happy to take questions now.
Thank you, Marina. Do we have any questions from the audience? I have a question. So I'm really interested in the gender piece because, you know, we talk about it's easier to find the adult daughters as caregivers. Was there anything maybe unique to the male caregivers that differed from the women, or, you know, anything surprising around that? Because it does tend to be women more often than not.
So I always say when I comment on this is to take it with a grain of salt, because I think in the end we had 2 sons that we ended up interviewing, which is where the richest data was. I didn't find any differences personally. Like, we did look at gender to see if there was anything that would come up that was different. We had the 2 sons that participated were very verbose and very open and happy to chat. So it was very similar to what you see with the female caregivers often in this type of research. So there was nothing that particularly stood out as being a male experience versus a female experience. The only thing I would say that maybe was a little bit different was more the caregiver to care recipient relationship. So if it was a daughter caring for a father, for example, when it came to personal care, that tended to be a sticking point because there were some issues of privacy and dignity, whereas if it was a son caring for a father, that didn't seem to come up as much, versus if it was a son caring for his mother, like they would say, I'm not going to go out and buy her nightgowns, like that's so that would really, it was more the relational piece of it versus anything in terms of the experience with the peer support. And in terms of even gender, with interacting with the same gender, there was nothing, like I expected that there might be something around, I'd rather interact with another woman, or it would be great for me to interact with another man who was caregiving, but none of that came up. I think the sons that I talked to, their peers that they focused on were women.
Comment more than anything else. There's actually the Ontario Caregivers Organization. They just launched their website last week.
The 24-hour helpline is up too.
Yes.
Yeah.
It's the helpline, and then links to like all the support groups and financial resources that Ontario offers for caregivers.
Yeah, if you follow me on Twitter, I've been tweeting about it all of last week, because I think that's amazing that we finally have something that's a central, point for caregivers to access resources and help provincially. Also, the thing that makes recruiting for caregiving research so difficult, I always say, is because we don't have a central hub for family caregivers. It's not like if you're doing stroke research and you're looking for people who've experienced a stroke, you can go to St. John's or try and go to the stroke ward, and there's your population. Especially with caregivers of just to generally older adults or the aging population, it's very, very tough to find them. So I'm curious to see if that central hub ends up becoming a resource to sort of push caregiving research forward as well.
Could you target them at discharge? So while you're discharging a patient, for example, in a hospital, is that an opportunity to target their loved one who would end up being an informal caregiver for?
Yeah, I mean, you definitely could. The research would have to be ongoing. The tough part is a lot of my research is community-based, so it's when they're out into the community and no longer associated or affiliated with the hospitals. And that's where I find it to be a little bit tougher. When it's inpatient research, it is a little bit more straightforward, although if it's acute or inpatient rehab, they tend to still be in crisis mode a little bit, so that's also a tough point at which to try to get them engaged in research.
Just curious, did your participants talk about how they found peers? Was it online? Was it somebody giving them a flyer? Because it's interesting that if you do an intervention, it's not necessarily as effective as if it's naturally occurring, but you need to create circumstances for that natural occurrence.
So I think of all the caregivers that I interviewed, off the top of my head, I want to say only one or two had actually spoken about a peer that they had developed a relationship with in the context of seeking caregiving related peer support. Everybody else said, my sister is my number one source of peer support, and she's also assisting with caring for my mom, or my group of girlfriends that I normally have lunch with all are experiencing the same thing as me, and they're the people I go to when I want to talk about the challenges I'm facing with caring with my parent. So with this population, there's an interesting universality phenomenon in that everybody is aging and almost everybody has an experience with an aging parent. I still remember one caregiver saying, I even sometimes get support from the grocery clerk who, I'll say something about my mom and they'll be like, oh yeah, me too, blah, blah, blah. And even in that short exchange, they're, sharing a piece of information or a piece of advice about what the clerk is going through and what the caregiver is going through. So again, because of this being so universal, I think they didn't have to seek out peer support. It was already there for them. This, of course, would be very different if it was a different population. It also makes me think a little bit about how can we capitalize on relationships that exist in terms of creating or enhancing peer support once people are back out into the community. Because when they're in rehab, they're interacting with other people who've gone through the same thing as them. Even families might be interacting with one another in hospital, and then they're out in the community and they don't necessarily connect anymore. And sometimes it's awkward to try to connect with somebody that you've never met, especially in an online setting. It doesn't feel natural the way peer support is intended to be. So I think there's a lot of, I would say, thinking work that needs to go into making any intervention or program a little bit more organic.
Any questions or comments? No. Well, thank you very much for an excellent talk.
Thank you guys for having me.